First off, welcome. Thank you for joining this webinar. I know many of you are going to be listening to the recording. I am Dr. Lisa Faast, CEO and owner of DiversifyRx, and I am on a mission to save pharmacies because I believe you all deserve to have profitable, fun-to-own pharmacies, and it is possible. You just have to change the way we do business. We just can't do pharmacy like we used to even a few years ago. You need new operations and new ideas, and part of that is this whole landscape of 2025 Medicare. And so I like to, I'm an expert in a lot of things. I like to learn new things, but I most definitely stay out of the lanes where I am not an expert. And understanding Medicare and really, frankly, contracts in general, besides the math, I love the math part of contracts. I kind of stay out of that lane, and I lean into super smart people who it's their day job to know those kinds of things. And our guest on today's webinar, Kyle Shin from ICBN, is one of those. I'd like to say he is a contract PBM nerd, and I say that with the utmost respect. And I bug him all the time with questions. He does some really cool things. He does this whole PSAO analytics thing to let you know, like, which PSAO or maybe direct contracting or whatever might be better for you. Really cool stuff that he does because he is just a top level nerd when it comes to contracting and really understanding the kind of different landscape of things out there. And so I'm happy to introduce him to you. Many of you might have saw ICBN at the summit last year. You will actually see more of Kyle coming up in March. We're actually going to be having him talk about the PSAO analytics and, like, is it better to, which PSAO is better for you? Is direct contracting better for you? And I will give you the spoiler alert. There is no one magic answer for everybody. It is completely different. So that is why we need somebody to Kyle to come in here. But before we get to March in the summit, we are here to talk about 2025 Medicare landscape. I know some of the questions I have that I've already been going back with Kyle and back and forth with our members, those of you that are part of Pharmacy Badass University on office hours, this whole Caremark contract and some of the PSEOs signing the Caremark contract, some of them not signing the contract. Like, what the heck are we supposed to do? I'm sure that's on a lot of your guys' minds. So any questions you have now, pop them in the chat. If they get answered during there, that's fine. If not, we'll just fire him at Kyle until he puts his hands up and says no mercy. So you can, again, use the chat, put it in there. I will be monitoring the chat because I'm going to turn it over. I'm taking off my host hat now and putting on my pharmacy owner hat. So I'm here to learn from Kyle just as much as you guys. But Kyle, take it over, and it is all yours.
Awesome. Thanks, Lisa. Really appreciate the chance to talk today with everyone about the 2025 Medicare landscape and how some of these contracts are going to shake out, and just some considerations for everyone as we go into annual enrollment season. Just for a little bit of background on myself, I know I have this baby face here, but I have worked in healthcare for about 10 years now. Initially, I joined McKesson in 2015 as a sales rep supporting independent pharmacy, but I worked with a lot of passionate independent owners and really just developed a passion for independent pharmacy myself. I joined right around 2015, right when preferred networks, DIRs, all that fun PBM stuff started to really blow up and dominate the conversation. So managed care is the only world I've known, and I transitioned over to Health Mart Atlas in October of 21, where I served as a subject matter expert for the field reps and the customers, and just did a lot of deep dives with customers about what was going on with their contracts, and more importantly, what were some potential levers to address some of the issues like low reimbursement, or knowing what plans might work better for the pharmacy, and which ones to kind of steer clear of. I became a certified insurance agent in the summer of 2021, just because I worked with a lot of pharmacies that provided those services, but were not being paid for that work. So ICBN has some pretty cool solutions that I'll hit on today that can help get you set up to be an insurance agent, or can help to partner you with an insurance agent if you don't have the bandwidth or wherewithal to go through that process. But before I get into some of the specific PBM contracts and what the landscape is going to look like, I just wanted to take a little time to talk about some of the overarching fundamental changes that are set to take place in 2025. Now, I know every year is a crazy annual enrollment because there's a lot of changes every year, but there's some pretty big ones coming down the pipe for 2025. In particular, one's tied to the Inflation Reduction Act that was just passed a few years ago. One of the biggest changes is the new $2,000 true max out of pocket for patients. This is a pretty far cry change from the 2024 setup that many of you are familiar with. This slide breaks out the current breakdown of Medicare benefits for patients here, but looking at 2024, we have that deductible phase that many of you are familiar with, where the patient pays 100% of costs until they reach that deductible. In 2024, it's $545. Not all plans actually use that deductible limit. Many of them either have no deductibles for things like tier one generic drugs at preferred pharmacies, or they have lower deductibles. But after that patient hits their deductible, they go into that initial coverage phase where there's that co-insurance where the patient pays 25%, and then the Part D plan pays 75%. They stay in that until they pay $5,030 out of pocket, and then they enter that donut hole, where basically they continue to have that co-insurance up to $8,000, where then they pay no out-of-pocket costs. The big reason I'm hitting on this is in that catastrophic coverage phase, you can see Part D plans pay 20% of the drug cost. That's going to be really important when we look at this 2025 breakdown that Medicare is moving to. So the big news is that donut hole is going away, and that max out of pocket is getting reduced to $2,000. So in 2025, that deductible max will be $590. Then the patient goes into that co-insurance phase where they pay 25%. And then after hitting that $2,000 out of pocket, they now pay zero costs, compared with the $8,000 potential limit in 2024. So that's a really big change at the surface. That sounds great that more Medicare beneficiaries are going to hit that out-of-pocket max and are going to have lower costs. But the important thing to understand is in that 2025 dynamic, you can see the Part D plan is going to pay 60% of the drug cost after the patient hits that $2,000 out-of-pocket limit. Currently in 2024, only about 11% of Medicare beneficiaries actually hit that $8,000 limit, and then the plan is only on the hook for 20%. Compare that with 2025, I'm sure you are already thinking a lot more people are going to hit that $2,000 limit. And then the Part D plans are going to be on the hook for 60% of the costs after that. So a lot of the insurance plans are starting to sweat and have a lot of heartburn about how they're going to be profitable come 2025. So what we're going to see is some trickle-down effects onto the Medicare benefits and onto the pharmacy reimbursement. So some of the predicted impacts from those changes are increased premiums on a lot of standalone Part D plans. Higher deductibles that impact more tiers of drugs. We're going to see a decrease in some of the ancillary Medicare Advantage benefits. So some of those flex cards where patients can get credits for food, OTC products, we're likely going to see a reduction in those, a reduction in the dental benefits. But a lot of contraction of the Medicare benefits is anticipated here. A lot of formulary reductions on standalone Part D plans. And unfortunately, we're going to see erosion of pharmacy margin in a lot of these Part D plans with these changes as the Part D plan sponsors try to remain profitable in this segment here. Now, I know that sounds scary because annual enrollment is always a very crazy time for pharmacies, but come next year, it's probably going to be one of the busiest seasons for us because there's some analytic companies that try to estimate how many people actually shop Medicare plans each year. Usually, on average, it's about 20 to 25% of people actually shop their Medicare plans. Now, not all of them actually change plans, but actually do a review about 20 to 25%. There are some companies that are estimating about 70 to 75% of Medicare beneficiaries are going to want to shop plans after they get that annual notice of change and see the premium is increased, the formulary has been contracted, Medicare supplement premiums are expected to increase a lot year over year. So be ready for a very busy annual enrollment season. And more importantly, if you don't do a lot of outreach around that time, be ready for some potential headaches at the counter where a patient comes in and maybe they didn't have a deductible in years past on that plan, and now they're going to have to pay $590 out of pocket before the insurance kicks in there. So I really encourage pharmacies to pull your patients, look at what patients are in those plans that are going to see some of these changes here, and start to get the word out to, if you offer any kind of plan comparisons during annual enrollment, make sure you target those patients to come in for a review so that you're just not having to deal with some of those headaches come January, when it's a lot tougher to help patients navigate it after that annual enrollment period closes out. But if you're feeling like you're on an island, the big thing I really want to emphasize is you're not alone. You have resources that can help you manage annual enrollment, manage those patient conversations, and just make it a successful season, even in spite of all these changes here. So don't be afraid to reach out for support, because you're not alone and there's some resources that can help you with it. So when looking at what options you actually have to improve the situation and minimize the impact, I just want to hit on some of the ICBN solutions that can help you in the lead up to this annual enrollment here. At the core of what ICBN, Independent Community Broker Network, does is they help pharmacies get set up with an insurance agency to actually monetize those Medicare inquiries. I myself, as an insurance agent, like I mentioned, I support a pharmacy chain, and it's a really great opportunity for a lot of pharmacies that I would really implore you to look at here. Obviously, if you own the process, you own the profits, and there can be a really good ROI going down this route of setting up an insurance agency and having someone become a licensed broker. It's very low cost, about $500 to $1,000, depending on your state. It is slightly time intensive with about 40 to 80 hours required, but there's a really great ROI on helping patients enroll into Medicare. You can see I have some of the numbers listed for the Medicare Advantage plans and standalone Part D plans. But if you have a new to Medicare patient enrolling into Medicare, you actually make $626 next year if they enroll into a Medicare Advantage plan. And insurance commissions become an annuity stream where if that patient stays in that plan for 3 or 4 years, which is about the average tenure for a Medicare Advantage plan, you make that $313 every year they renew in that plan. If you're just looking at plan changes during annual enrollment and they switch from United Healthcare to Humana, you make that renewal commission each year as you help patients change plans after they're into Medicare. So just want to do a quick plug about the potential ROI, and that really is the core of what ICBN does. I myself went through the ICBN process and am an agent underneath them, and they just have a lot of great resources to streamline that process and really hold your hand through the agent setup. since we're late in the season, you're realistically not going to be able to get that set up by annual enrollment. So I would really encourage you to look at maybe partnering with an insurance agent in your area that can help do a lot of the heavy lift for you come AEP here. And I think I've seen a few hands come up. Lisa, if there's anything that makes sense, please interrupt me. I'm from Chicago, so I talk fast and throw up a lot of info, but don't be afraid to cut me off here if questions come up.
Yeah, no, absolutely we will. So far we have questions about what about your Medi patients, your dual eligibles? How's that? And then if the PDP premiums are capped at a 6% increase, how does that play in? So those are the two questions at this time.
Yeah, so it is kind of interesting. CMS, when they got the initial estimated premium increases, they were seeing about a 3x increase on the average premium. They did step in and are now subsidizing the health plans when they have people enroll into Part D premiums, and they have capped the premium increases at about 6% there. So it might not all happen in this year that we see a lot of that premium increase, but year over year, Part D premiums are just going to continue to increase, and especially on the Medicare supplements that a lot of patients are on, that's where they'll likely see a lot of that heavy premium increase. A lot of companies that maybe did 5 to 6% increases year over year might see 10 to 15% increases, which is naturally going to steer a lot more people towards Medicare Advantage or just wanting to shop those Medicare plan options. As far as the Medi patients go, there are some slight changes to the enrollment periods for them. So currently, Medi patients can change plans once per quarter for the first 3 quarters of the year. So January through September, they can change plans once per quarter. That's actually moving to once per month come 2025. So if you do have those Medi patients, there's a lot of opportunity to shift them into different plans come next year, even if they don't come in for their annual enrollment review. But if they are a QMB status individual with Medicaid, they would have their premiums and coinsurance still covered under the state Medicaid program. So if you have a lot of Medi patients, you are going to be a lot more protected from some of the changes that are coming down the pipe here, because they're going to continue with that state Medicaid program in many cases, and we'll still have that coverage. But big thing is that change to once per month to actually have a special enrollment period to change plans if needed. So that's where really there can be a lot of opportunity if you know what plans work well for the pharmacy to help get those patients into plans that work better for the pharmacy. And what I usually look for are win-win opportunities where we can get the patients extra benefits that also just by happenstance maybe have better reimbursement for the pharmacy. And what you really want to target with those Medi patients, many of them, when they become Medicare eligible, they get auto-enrolled into maybe a standalone PDP plan, and then they have original Medicare with Medicaid that basically acts as a Medicare supplement for those patients. What I would really encourage you to do is if you partner with an agent or if you set up your own agency, those are prime patients to look at dual special needs plans. Not many Medicare, Medicaid patients do reviews because they have Medicaid that covers their costs and it works well in a lot of cases. But if you partner with an agent or get the ability to talk about Medicare Advantage plans, PPO dual special needs plans oftentimes have strong reimbursement for the pharmacy, but get the patient dental, vision, hearing coverage, and they include really robust stipends for patients that can be used on food products, OTC, even utility bills now can be covered by these dual special needs plans. And they typically have anywhere from $150 to $250 a month in these credits that patients can use for that. So that's what I would really encourage you to look at with those Medi patients. If they're on original Medicare and a standalone Part D plan, see if they want to talk about a dual special needs plan. If you can get them out of, say, WellCare or a Cigna, if you're direct contracted, and into United Healthcare's PPO dual special needs plan or Humana's, you can see anywhere from a 5 to 10% lift on the brand reimbursements. So that's where I'd really encourage you to focus your time and attention if you have a high Medi population. But since we're kind of late into the season here, or if you just don't have somebody with the wherewithal or bandwidth to take on becoming an insurance agent, I'd really encourage you to partner with an agent to do that heavy lift for you and help you kind of navigate some of these nuances like Medicare Advantage plans. One thing I typically see is a lot of pharmacies that do plan reviews for patients. They're really limited to only talking about standalone Part D prescription drug benefits. When you're able to open that conversation up into Medicare Advantage, special needs plans, Medicare supplements, you really just enhance your patient care at the end of the day, because now you're doing a more comprehensive review and you're able to really align them on the plan that best supports their individual needs. Insurance agent can definitely help you with that and can be a really great partner for a pharmacy. If you don't have people in your area, or you're really not comfortable doing that outreach and trying to find someone, ICBN does have a nice service called The Road Ahead, where they can actually try to help find an agent in your area that can be your strategic partner. So they can do a survey of the market, try to find someone, help you have that conversation, and then come up with some of those best practices to really maximize partnering with that agent. But if you have any heartburn or concerns about the lead up into annual enrollment here, partnering with an agent can be a really great option for you. And then if you can't find an agent in your area, there is a Patient Connect solution where they basically get a permission, you basically get a permission to contact for your patient, and then they route that to one of the ICBN agents that is licensed in your state and can, from a virtual or remote place, actually help that patient navigate Medicare. So reach out to ICBN if any of these solutions are of interest to you, but partnering with an agent or starting an agency can really be a great way to either improve your profitability or just take a lot of that burden off of the pharmacy's plate. So now I'm going to transition over to talking about the Med D landscape in terms of reimbursement and contracts that are out there. Before I start going through some of the major PBMs and plans, I just want to take a little bit to talk about some important terms and formulas. So what we're seeing on a lot of the Part D contracts is what's called maximum AWP discount. I think one thing that's given a lot of pharmacy owners a lot of heartburn when they're looking at the 2025 contracts is a lot of the contracts have pretty ugly rates listed in the actual solicitation. But what's important to understand is in a lot of cases, that is the maximum AWP discount is what they refer to it as. What that means is you are not going to be paid that discount on every prescription. So Aetna, for example, has AWP minus 22% for the maximum AWP discount. But if you actually reach out to Aetna and ask them about how they're going to actually deploy that contract rate, they'll tell you many of your brand products are going to see similar reimbursements to today. That minus 22% that's in the contract is just the lowest you can be paid on individual prescriptions. Now, it's still a little bit of a leap of faith that they're not just going to take every brand prescription to that minimum discount, but it's important to understand that dynamic that that is just the lowest potential you can be paid on individual prescriptions. But if you reach out to Caremark or you reach out to Aetna and ask for some clarification about what you can actually expect at the point of sale, they'll tell you pretty bluntly that they're not intending to manage every prescription for that lowest discount, and many brands will be reimbursed similar to how they are today. But it's definitely given me a lot of heartburn to have to take them at their word for that. But important to understand that dynamic when we actually talk about some of the contracts here coming up. And then a lot of the contracts are in AWP minus percents. I know that that can be tricky for pharmacies to try to understand what does that actually mean for me in terms of profitability. So I put 3 common brand cost of goods that pharmacies buy at. As you know, pharmacies buy in terms of WAC minus a percent, and then you're reimbursed in terms of AWP minus a percent. On brand medications, those numbers are directly tied together. So the AWP price for an item equals the WAC times 1.2, or the WAC equals AWP times 0.833 repeated. The important thing to understand from that is when you understand how some of those numbers connect, you basically understand all brand products and economics across the board. So keep some of these numbers in your back pocket if these are close to what you buy at for your brand cost of goods. But the napkin math you can use is WAC minus 4 is directly equivalent to AWP minus 20%. WAC minus 5 is directly equivalent to AWP minus 20.83, and WAC minus 6 equals AWP minus 21.67. I included a little profit calculator just to help translate it a little bit better to actual gross profit per script. But if you have a brand product that has an $800 AWP price, this shows if you buy at WAC minus 4, what do you make on a prescription if you're paid at AWP minus 18 versus AWP minus 22? So if you buy at WAC minus 4 and you're reimbursed at AWP minus 18, you would make $16 on an item with an $800 brand AWP. And that's pretty typical for what we see for a lot of AWP on brand products. On the flip side, if you're reimbursed at AWP minus 22 and you buy at WAC minus 4, you're going to lose $16 on that prescription. But hopefully that just helps to make it a little bit more real in terms of actual dollars per script, and just helps you connect the WAC price and AWP as we start to look through some of the contracts, or as you get those solicitations moving forward. And then on generics,
interject here for a minute, just because we're talking about brand pricing. So almost, I won't say 100%, but close to 100%, pharmacies just don't make money on brand name drugs for Medicare. It's because, they're all at the minus, 22% in there, and we all pay WAC minus 4. My contract with my GPO is WAC minus 4.5, so it gives us a little bit of leeway. And so many pharmacies like us and our pharmacies have just stopped filling the brands. We've transferred the brands to mail order, or whichever way. I'm a big fan of Retail My Meds, doing some kinds of things where we're just not filling brand names anymore. And so yes, I'm concerned about these brands. I think it sucks that, we lose money, but for those pharmacies, as we start to look at the contracts and stuff, the generics become more important because we've just gotten rid of that brand name, book of business, so to speak. And so the generics are, obviously they're MAC rates, but are we able to know which plans are better? Like, so if I'm helping somebody pick a plan, whether I'm a Medicare agent or working with somebody, and I know that the brands don't matter, maybe because I've already transferred out most of those, is there a way to determine like who has better MAC pricing, like to make that generic book of business better?
Yeah, great question. It is really tough when you're just looking at a contract rate, because the contract for generics usually just lists MAC. And basically what that boils down to in the contract is PBM gets to set the price. They can update it at will. And the pharmacy agrees to accept that price when we adjudicate the prescription. Some of the plans, though, where I usually see better generic trending is United Healthcare and Optum. Um, some of them, like Aetna and Humana, I have a little bit more heartburn on the generic MAC rates, but you can kind of look at your trending today and just assume a little bit of erosion, but usually we don't see huge changes year over year in terms of MAC reimbursement. So I would say look at your current profit on those plans and use that as a rough approximation for what plans would be better for you come 2025. One thing that makes it a tougher to kind of do a high level, hey, this plan will be better for you, is there can be big swings, in certain regions that sometimes have better reimbursement than other regions. Aetna is one where some areas it seems like pay pretty well on generics, and other regions they're one of the most aggressive on generics. But usually United Healthcare and Optum plans are where I see some of the better generic trending year over year, looking at some of the historical trends there.
All right, awesome. Thank you. I agree with that with Aetna. Aetna, at least in my Louisiana store, was absolutely, it was something like 85% of generic claims were like below water. It was up. We got rid of that.
Yeah, and as we start to look through some of these PBMs, there's going to be a lot of shakeups in terms of just plans available in your market as well. We're seeing a lot of plans actually exit the market. Aetna, for example, is exiting 2,600 counties for Medicare Advantage. And the big change with Aetna come next year is there's currently 3 standalone PDP plans offered. There's the SilverScript Smart Saver. If you opt into the P3 network, that's the really low premium one. Usually it's like $2 to $7 for that Smart Saver premium. Then they have the Choice Plan, which is that one that's around $30 to $40. And then they have that Plus Plan, which is the one that's around the $100 for the monthly premium. They're actually dropping the Smart Saver and Plus Plan and are only going to offer the Choice Plan come 2025 here. So that's a perfect example where I would pull your patients that are in that P1 or P3 network if you're opted into that, and just give them a heads up that, hey, your plan is going to be exiting the market come 2025. They're not going to crosswalk patients to the Choice Plan, so they're going to have to select a different plan to have continued coverage come 2025 here. But that's some really low-hanging fruit to just start to be a good steward for your patients and get ahead of some of the potential headaches that you might see come January here when patients bring the scripts in to actually fill up. But Aetna, I think, is a good jumping off point here. We're going to start with Caremark in terms of what the contract looks like in 24 versus what it's moving to in 2025. So in 2024 here, Aetna actually has one of the better contract rates for brand medications. Currently, they sit at a max discount of WAC minus 1.6%. They are a PBM that I see typically pay at that contract rate in 2024 here. And then they, like Lisa mentioned, have some pretty aggressive trending on generics in certain pockets. But that Smart Saver and Plus plan are leaving, and they're only going to operate the Choice Plan come 2025. The reimbursement rate in the contract, I've seen a lot of pharmacies raise some issues about it. They are moving to a max WAC discount of 6.4%. So when I first got that solicitation for the pharmacy group that I work for, I reached out to Aetna and right away asked for some concessions on that, since if we're paid at that max discount, we're going to be below cost pretty substantially on those medications. They actually responded to me in writing saying, many of your brand drugs will continue to be priced similar to how they are today. So it's tough that we have to take them at face value, but I'm, I guess, naively optimistic that they're not just going to tank the rates and pay us at that max discount on all of our products. And basically, we'll have some that we see close to today that we're paid pretty well on. Some of them we might lose some money on, but hopefully, in that aggregate blended experience, we're going to come out relatively close to where we are today, or maybe just a little erosion. Like Lisa mentioned, though, if you do selective dispensing of brands, you don't have to worry about post-adjudication true-ups in Medicare anymore after that final ruling that did away with DIR fees. So you'll have to play it a little bit by ear and actually look at what you're paid at the point of sale. But I'm hopeful that we're not going to see a huge drop off come next year, and they're not just going to pay us at that 4 to 5% more aggressive on many of our prescriptions here. But that is a contract that uses that max discount language. So it is not all doom and gloom just because we see it at minus 22% this year versus minus 18 in 2024 here. Looking at the other Caremark business, though, in 2024, they have what they call their 24D network, where they have 3 different fee schedules. Fee schedule 1 is for Anthem or Elevance plans. That also pays pretty well at WAC minus 2.5 to 2.65, depending on your PSAO or direct contract there. And then all other Caremark plan sponsors fall into fee schedule 3 on the 24D network, which is around WAC minus 6.4 to 7.3. So if you have some regional Caremark plans, you might already be seeing some aggressive brand reimbursement in 2024 here. What they are moving to in 2025 is they have their Aetna network that'll be at that max discount of 6.4, and then they just have one retail network that they're going to operate that they're going to put all of these plan sponsors into. So on the direct contract, or even one of the both of the PSAO contracts for the 2 that did end up signing it, they all have the same max discount in the contract of 7.3% off of WAC. Now, that, just like Aetna, is a max discount arrangement. So my hope, again, is that they are not going to just tank every plan sponsor and every prescription to that max discount. And one thing that I think is really helpful is one of the PSAOs that secured a Caremark 2025 contract. They still have that minus 7.3 off of WAC for the max discount that you can be paid on individual prescriptions, but they secured a cap on the network's aggregate experience. And I think it's really helpful if you look at what they secured for the individual plans, because my best guess is that they didn't secure a material improvement over the direct contract or over that other PSAO because they still have the same max discount on individual items. My best guess is that they were able to clarify with Caremark where do they actually intend to manage some of those individual plan sponsors. So you can see Elevance and Anthem on the bottom are broken out at 3.9 to 4% off of WAC. That is a little bit of erosion compared with this year, but many pharmacies can still be profitable on that 3.9 to 4% off of WAC, or at least break even on it. So if you are direct contracted, if your PSAO isn't one of those 2 that secured it, my hope is that they're not going to pay all the claims to that max discount. That was just a way for them to consolidate some of the networks, and that we'll see similar rates, even if you're direct contracted, to what that PSAO that did sign it with that aggregate cap for their network secured. Now, obviously, I'm just making an educated guess, but that's what I'm anticipating seeing for the direct contracts come next year. If you have Elevance and Anthem plans, or if you have Molina in your state, you can see they're listed at minus 4.6%. Might be slightly different compared to what you see on the screen here, but Caremark, similar to Aetna, did state that the aggregate experience, even on a direct contract, will be significantly shallower, was the words they used to me, come next year. So I don't think they're intending to just tank every prescription to minus 22.7%. I think it depends on the plan sponsor and the aggregate experience. If you have Elevance and Anthem, will hopefully land close to that 3.9 to 4% off of WAC I have on the screen here, or Molina will be at that minus 4.6%. If you have any other Caremark plan sponsors, I would be cautious that that might be a case where you actually see them pay at that WAC minus 7.3%. But if it's Aetna, Elevance, Anthem, or Molina, I'm hopeful we'll see rates close to what I have listed here, or at least close to the 2024 contract in Aetna's case. So I know that's a lot, and it's a little bit tough to unpack here, but anybody have questions hearing that Caremark breakdown?
I think there's a bunch that popped in there. Well, and people stop talking about the slides. I'll ask them about slides, and if I give it to one, I'll give it to all. The Caremark with obviously the PSAOs, if they want to sign up for the Caremark plan and they're with the PSAO that didn't sign it, so like let's say the Align people, okay, there, it's on your slide. How do we manage all that? Because there are some people that are going to want to do the opposite of whatever their PSAO did for whatever reason. That's their business decision. And then, do you have any unofficial opinions on what pharmacy owners should do?
So what I would encourage pharmacy owners to look at is, what are the Caremark plans in your area? I'm hopeful that if you have Anthem and Elevance, if you're one of the Blue Cross Blue Shields in your state uses them, I'm hopeful we'll see close to that WAC minus 4%, and that a lot of pharmacies can still be profitable in it. If you have one of the ones I didn't list, I would be a little bit more cautious about signing that contract, or if that might be a really good target to ask those patients to come in for a review during AEP to see if maybe there's a plan that better supports them, that also works better for the pharmacy, like United Healthcare. But what Caremark did is they're one of the goofy PBMs that gives pharmacies the option to contract direct, or you can use your PSAO affiliation if your PSAO has a contract with them. But what they did was they sent out back in March the 2025 Med D contract. And what they set it up as is an opt-out contract. So you had until the end of April to opt out on your base direct contract, or you were automatically enrolled into the 2025 Med D network. If you did opt out and your PSAO declined, you can still opt in by messaging Caremark and asking for that 2025 Med D solicitation. If you did opt out, you may have just seen they sent a notice that you have until 9/28 to send them that solicitation and rescind your opt-out request back from April. If your PSAO declined it and you did nothing and didn't opt out back in April, you are in network, and there unfortunately is not a way to get out of that contract until 2026, potentially. If your PSAO accepted, you can still be out of network if you sent them that opt-out request back in April by moving off of the PSAO contract onto your base agreement. Caremark can be carved out from the PSAO, so you can go direct with Caremark, and then have your PSAO manage all of your other contracts for the PBMs they hold contracts with. But hopefully this slide just helps to understand what to expect depending on if you did opt out or didn't, and some potential recourse if you do want to get into network. But unfortunately, if you want to be out of network, that window has passed for 2025 there.
So Kyle, I've slept since April, and I, theoretically speaking here, if I don't remember what I did, or somebody's here and it's like, man, I get so many faxes, I don't remember what I did or didn't do. How can I find out if I'm opted out or opted in?
I would reach out to Caremark's, I believe it's the RX Farm Services, something like that. They have an email inbox. Lisa, I can shoot it over to you. And then if you maybe want to send that out afterwards for people to have, it might be a little bit slow to get a response just because they're getting absolutely overwhelmed in the lead up to AEP here. But I would just reach out to them and just say, hey, did I opt out, or am I going to be in network for 2025 there? All right, so if no questions on Caremark, I'm going to move over to Optum, which is going to be pretty quick because there are no changes in the contract rate from 2024 to 2025. Every contract, whether it's PSAO or direct, is actually exactly the same at WAC minus 2.8%. They also use that max discount language. So one thing that's pretty interesting is if you actually pull your point of sale reimbursement with United Healthcare, you'll probably see it paying actually better than that contract rate and probably closer to WAC in terms of what you're being reimbursed. So there is the potential for slight erosion at the point of sale in 2025, because even though the contract rate is staying the same, they're currently paying better than the contract. So if they do pay at the contract, we might see a little bit of a reduction in your actual brand profitability and brand gross margin. But even if they pay at the contract rate, that's still a really great contract rate and is actually one of the best out there at WAC minus 2.8%. They also are one of the largest dual special needs operators in the market. So most areas and counties have a United Healthcare dual special needs plan. And that is actually one of the best paying for pharmacies when I've looked at it for our stores. So that's where you can find some really great win-win opportunities where you can get those patients the $150 to $200 a month in food credits, OTC, even utility bills can be paid for using their dual special needs plan. They also feature some pretty robust dental benefits. So if you have those Medi patients and your state Medicaid does not cover dentures, that can actually be covered on this dual special needs plan. If they're just on original Medicare, a standalone Part D plan, and have Medicaid that's filling in those gaps, they don't actually have any dental benefits. They don't actually have any hearing benefits or vision. You can add that to them by getting them into that dual special needs plan. And in many cases, that just coincidentally happens to benefit the pharmacy. But the big thing is no change in the contract rate. My best guess is we will continue to see them be one of, if not the best payer come 2025 here. And you can see my little snippet on there because it is so tough to look at generic trending and what to anticipate. My best guess is that they will be not awful on generics is the best that I can kind of frame it up as. But that's still better than many of these Part D payers, compared with being truly awful. So if no questions on United Healthcare, I'm going to jump to Humana, and then we'll cover Express Scripts, or save the worst for last. With Express Scripts here. Humana is also going to be pretty quick here. every contract is the same because no PSAO holds a contract with them. Everybody is at the same WAC minus 6%. But the big thing to know with Humana is if you have a lot of Medicare Advantage patients, or if they have a dual special needs plan in your area, you can earn up to an 11% rebate on that Medicare Advantage business. It is based on your clinical performance, but there's 3 tiers. Lowest tier, you get a 0% rebate, or you'll just be paid what you're paid at the point of sale. The next tier is a 2% rebate, which will put them around WAC minus 4 on brands, or you can earn an 11% rebate. So if you do $100,000 in Humana Medicare Advantage business, you can earn an $11,000 rebate. If you earn that max 11% rebate, they will be your best payer on brands. And they have some pretty aggressive trending at the point of sale for generics. But again, that 11% rebate is really going to help to close the gap on that generic business there. So they also offer a lot of dual special needs plans in a lot of counties out there. Usually it's between Humana and United Healthcare that I see for the dual special needs options when looking at the national plans out there. But if you do have a lot of Medicare Advantage patients or a lot of Medi-Medi patients that you help get into that dual special needs plan, definitely check Equip and make sure you're earning that 11%. I always recommend just pull all of your Humana patients and get them med synced because it's basically just the adherence measures they're looking at for that rebate. And if you earn that 11%, they're going to be your best payer on brands in particular, and you'll be earning WAC plus about 3 to 4% after that max 11% rebate. Now I'm going to transition over to Express Scripts, who is far and away my least favorite Part D payer out here. They, similar to Caremark, give pharmacies the option to use the PSAO affiliation if your PSAO has one, or you can carve it out and contract direct. Express Scripts is actually pretty interesting in that they have the largest delta of any contract out there between commercial and Med D when comparing the PSAO contracts to the direct contracts that are out there. Commercial claims can actually be a little bit better in some unique circumstances when you contract direct, but Med D will take a significant hit on brands compared with one of the 2 PSAO contracts that are out there. 2 PSAOs will have a 2025 Med D contract, and it ranges from WAC minus 6.2 to WAC minus 7.75%. They use variable rate language, so it's a little bit different from the max AWP discount that Aetna and Caremark are using, where Aetna and Caremark, that is the minimum that you can be paid on individual claims. You cannot be paid lower than that contract rate. Express Scripts uses variable rate language where basically they only have to pay the overall network to that contract rate, the minus 6.2 or 7.75, depending on which PSAO. But you might have some claims that are paid way more aggressive than that contract rate is what's unique for Express Scripts. Now, if you're with one of those 2 PSAOs and they end up underpaying the overall network, there is a little bit of refund money that comes on the back end. But I have seen, probably 80 to 90% of brand medications are paid right at that contract rate if you're with one of those PSAOs. But there are some items and some molecules out there that they pay closer to the direct contract rates. And the direct contracts are the worst out there. of either commercial or Med D. And if you're direct contracted with them, you're going to be paid around WAC minus 10.6 to 11.2% for your standard day brands. I updated the profit calculator here where
You have to go a little further out, a little more negative.
a little bit more negative there. So that's the number one area. I would really encourage you to get patients to come in for that plan review and try to help them find a plan that might work better for them, and just happens to also benefit the pharmacy. But pretty much any other plan will be better for the pharmacy if they're on brands and you're direct contracted and not using one of those two PSAOs out there. I'll go ahead and pause there because those were the big PBMs that I wanted to cover today, and that will cover probably 90 to 95% of the prescriptions for pharmacies. But I'll go ahead and pause and just see what questions might you have from that.
Yeah, we have a ton of questions. Before I scroll up, we're on this slide. Which PSAO signs which contract?
So the two that have 2025 ESI Med D contracts are Health Mart Atlas and LeaderNet. If you want a little bit better granular detail, reach out afterwards and I can help get you some of that info, but I don't want to discuss that on the call here directly.
All right, so I'm going to fire these at you. Does it require state testing to become a Medicare agent?
It does. Every state has a state exam, to my knowledge, that you have to pass. Some of them have what's called a pre-licensing course that you have to pass. That can vary, where some states you can walk in off the street and take that state exam. Some of them you have to do a 8 to 20 hour course in some cases to be eligible to take that state exam. And then after you pass the state exam, you also have to get what's called AHIP, America Health Insurance Plan certification. It's basically, the analogy I like to use is the insurance exam, and getting your general insurance cert is kind of like your major. And then the AHIP is kind of like a minor that specializes you in Medicare plans specifically and makes you eligible to sell Medicare products. That's just an open book exam that you can take from your home. So usually once you pass the state exam, you're off to the races, but you do have to do some annual training and test with each carrier that you want to be able to get commission for. But again, that is an open book exam you take from your home. So a lot easier to pass those exams than the state exam. But great question there.
Another great question here that I get a lot, and I'm sure you do too, is how can I as a pharmacy suggest a Part D plan, because you're always told that you can't steer patients. And does my licensed insurance agent need to be separate from my pharmacy? Can it be in my pharmacy? Can you just talk a little bit about that? Because I think so many pharmacists are so scared of that steering. And they don't go forward with these, or they don't make any suggestions. If they have a patient on Express Scripts and they want to switch them to the United Optum, they're like, oh my gosh, I can't tell them that because then I'm steering and I'm violating, some rule that I don't even quite understand.
Really, really great question. And this, I think, is why it's important to have a partner like ICBN that specializes in having that integration between agent and pharmacy. But you do have to have some really important delineation where it's a separate LLC and business that agent operates under. And at the end of the day, you have to do what's right for the patient. It's not just steering them into plans that help the pharmacy but are worse for the patient. So it's about finding those win-win opportunities. But ICBN has some really great resources about how to compliantly market to those patients and have some of those firewalls between agency and pharmacy so that you can remain compliant. And then at the end of the day, it's just about doing what's best for the patients.
Yep. I agree. Going back to the special needs plans, what qualification is there? Obviously some qualification is needed. So like how does a patient get those special need plans?
So it varies by plan. Some of them accept lower levels of Medicaid subsidy. Usually it's called Slim B, where they're not a full Medicaid beneficiary, but they can be eligible for the dual special needs plans. Usually, though, what I recommend is only recommend those plans to patients that have full Medicaid or QMB status, is what it's called. Insurance agents actually have some tools that you can plug in the Medicaid ID and the Medicare information, and it'll tell you if they're eligible for that plan or not. Or if you partner with an agent, they'll have those tools as well that can do that determination for if they're eligible or not. And then it's important that you stay close with that patient, because if there's any change in their Medicaid status, the dual special needs plans will let them hang out in it for a couple of months to either reestablish that Medicaid status or pick a different plan to move to. But usually there is 20% co-insurance on pretty much every service that you would get through the Medicare plan. So doctor visits, going to the ER, many of that is 20% co-insurance if Medicaid is not footing the bill. But if they have that QMB status, Medicaid covers all those costs. If you pick a PPO dual special needs plan, I usually don't recommend HMO plans because they have, requirements around having to get referrals from your primary care physician to see any specialists. So I usually just look for PPO dual special needs plans. And then, one thing I think a lot of pharmacies are concerned about is when you look at Medicare Advantage plans, there can be network restrictions where not everybody is in network on all the Medicare Advantage plans. A lot of that, though, is really just lingering memories from when Medicare Advantage first got started, and there really weren't robust networks. Nowadays, if you're looking at the major Medicare Advantage plans like UHC and Humana, if you're in a rural area, it can sometimes still happen where they don't have all the providers in network, but most of the urban areas now, people are in network for it. And when you become an agent, ICBN actually sets you up with some software where you can plug in the prescriptions, you can plug in the providers, and make sure everybody's in network and everything is covered. And if you're currently paying for Amplicare to do that service, you actually can drop Amplicare and use the tools that ICBN provides to do those plan reviews. And just for an example of how backwards our industry is, a lot of pharmacies pay thousands of dollars for software to do that work for free. Agents get that software for free and get paid to do that work. So really great opportunity becoming an agent.
Don't make us feel even worse. Don't even. Question, are these rates that you've been showing on here, are they for standalone Part D, or are they for Advantage, or are they the same?
So it should be pretty consistent whether you're looking at PDP or Medicare Advantage in terms of the contract rate. There can be some differences where the MAC reimbursements can be different in some of those Medicare Advantage plans, but for the most part, the Medicare Advantage shares the same networks as the standalone PDP plans there, and should be consistent with what you see. Exception being Humana, you can actually earn that 11% rebate that makes the Medicare Advantage better than the standalone Part D.
Yes. Somebody was asking if Caremark has a contract that says WAC minus 7.3, but we're all just supposed to in good faith say, oh no, they're not actually going to do that. Why wouldn't they just do the worst? Like, is it to bait us into those plans and in 2026, really ream us? Like, we're all conspiracy theorists here, when it comes, but why wouldn't they pay at that rate if it is a max rate?
Yeah, that's where you kind of got to trust your gut and make your individual determination, because they definitely could just tank the reimbursements to that lowest experience. But I would say, I know PBMs get a really bad rap for a lot of really good reasons, but at the end of the day, they do recognize that pharmacies are a partner for them, and they need to keep a strong network to have, proper adequacy for CMS and to be able to have good star ratings. So, there's the potential that they will tank it to that, but I don't think it's in their best interest. And I think they recognize that if they drive every pharmacy out of business, that is going to be short-term gain for a lot of long-term pain that I don't think they want to deal with. So I am naively hoping that we'll see a little bit of erosion on some of those plans, but that we're not going to see a huge drop off compared with where we are here today in 2024. Just because at the end of the day, they do know they need pharmacies to continue to be able to operate those plants at the end of the day there.
I don't know that I'm as optimistic as you. Jason here wanted to share, he said, we also saw Humana paying wildly different for different NDCs, irrelevant to AWP. For example, for metoprolol claims, Dr. Reddy and Zydus, compared to others, paid triple, even though the AWP was the same. So I know I see that a lot too, Jason. I use Ugo software to see that. And it can help, especially on those Medicare, Medicaid plans, for you to understand which NDCs, for whatever reason, who the frick knows. I think I've stopped trying to figure out the logic to all of these, in order to what plans pay. Chris had a question. Our group, he says MA patients. I'm suspecting that means Medicare Advantage. So our group
Yes.
Medicare Advantage patients still not eligible for performance rebate in 2025, like in 2024?
That is a great question. I will clarify. I assume you're referencing Humana.
I would assume so too. He didn't say that.
I'll reach out to Humana's performance team and get that clarification. And then Lisa, if I can send that to you to maybe send a follow-up with
sure
that.
Will. Yep.
Awesome.
Let's see. When will the 2025 plan premium info be solidified and released?
So insurance agents have already received the first look in many cases. I want to say, though, it's October 1 that a lot of the plan finders and software updates to be able to start to see some of the actual premium changes, because usually the plans mail out the annual notice of change right towards the end of September, so that come October 1st, that hits the beneficiaries and they can see all the changes associated with it.
Right.
WellCare value script will continue to be the lowest premium Part D plan option. They did stem off a lot of the potential increase because the government is going to be subsidizing them. And then they also made that plan non-commissionable with insurance agents. So that's pretty frustrating if you do become an agent and have a high WellCare population. But definitely see if there is a plan that might better support them. I think a lot of those patients are auto-enrolled if they're Medi-Medi. A lot of states have partnerships where WellCare is the benchmark plan. So if you do have a really high population and you're in one of those states that auto-enrolls Medicaid patients into WellCare, that can be a really good option to target for the dual special needs plans in particular. But that is something I'm concerned about as well, is even though WellCare is the worst plan for the pharmacy, if it's far and away the best plan for the patient, insurance agents are not magicians and wizards and can't just, make patients go into plans that are not as good for them. So that's something I have a lot of concern about. But if you are direct contracted and have a lot of WellCare patients, it might be worth looking at one of those PSAOs that does have a Med D contract, because there is such a delta, and you can see a 3 to 4% lift just by moving to that PSAO affiliation. So I know we're over on time. I know we're going to be wrapping up here, but if anything that I said resonated with you today, ICBN does also have some PSAO light services that help to fill in some of those gaps PSAOs leave. If you found any of this info today beneficial, you might benefit from looking at their PSAO light services, but they can give you all the breakdown of what PSAOs actually have it, what impact would that be moving over to that PSAO, what are some other considerations like the effective rate difference, and basically giving you all that support to help fill in the gaps so that you can actually make informed decisions about your PBM contracts there.
All right. Go ahead and finish up, and then I just want to let everybody know after this last slide, we'll stay on and answer some questions, so it'll be in the recording, but I want to make sure you guys get all the information. So go ahead on this very last slide, because I think this is super important.
Last slide, I hit on it with those dual special needs plans. If you have a lot of patients that bring in those flex cards, that can be used for OTC products, food if you carry that at your store, personal care items, DME, all of that can be paid for with the dual special needs benefits. If you're not in network and you have a lot of patients that bring those cards in, scan that QR code on the bottom. ICBN has a partnership with Solutran and ProHealth that manages those cards. You do have to get a separate terminal that's sent out to the pharmacy. It's a cell phone sized device that they send you, but then you can actually process the United Healthcare, Humana, and there's a lot of other plans that they cover that you can get set up to capture those dual special needs, or even the Medicare Advantage plans have a lot of OTC benefit cards nowadays. So definitely something to look at. That way you can capture the money from the enrollment. If you do become an insurance agent or add that agency dynamic, you can help them get into plans that benefit the patient and the pharmacy, and then you can capture that OTC card and really just diversify beyond the prescription and bring everything full circle with that.
All right, so questions on there, and the terminal, just so you guys know, you do have to use an external terminal, which can integrate with every system. There's no problem with that. You do have to pay for that external terminal for the equipment. You can also opt to use an app. So if your employees have cell phones, or you maybe have an iPad in the pharmacy, you can use an app, and there's no charge for the app. So if you don't want to dole out, I think it's $350 or somewhere around there for the terminal, you can use an app. So just FYI for those, that there are two options there. All right. Questions. How would I switch a patient if I'm not working with an agent?
So what a lot of pharmacies that I've seen will do is they'll just provide a review for them and help them know, here's what you can anticipate in terms of potential costs, but they will not do the actual enrollment with the patient. They just kind of provide that information to them and send them on their way. That is compliant for a pharmacy to help patients understand that piece. You just can't really recommend plans and enroll them into that plan if you're not an agent. But if you just say, hey, here's the 3 best potential plans based on this software that I use, my understanding is there's a lot of pharmacies that do that, and that's a compliant way that you can help them understand potential costs and impact for next year's plans.
Okay. Yep. Can you scroll back to the Caremark slide and just have that up there? And then let's see. There was for Humana's rebates, where are the scores posted, and how do you know where you stand to know which rebate you might be earning?
So there is a module in Equip that Humana has built out where you can see how many patients you have in there and who is dragging down your score. I don't think they've fully loaded it though, to see like actual dollar and potential rebate impact. My understanding is that usually happens right around the end of the year that they finish getting all that information loaded. But there is a module in Equip they built out where you can start to see patients that are included in that Humana rebate there, and if they're currently adherent or not.
All right. And must you be signed up with ICBN? Like, must you be an agent to get to use the software program that you were talking about?
Um, yes, it is set up with you as an agent. I don't know that there is an option that it can just be used if you're not an insurance agent. Let me check though, because there is a public facing component to that where when you become an agent, you basically get a custom URL that you can send out to clients and they can self-enroll and you can still get commission for that if it's one of the commissionable plans. But I believe it has to be linked to an agent. And if that agent is not contracted with all the plans, they won't all display for that patient to do a full assessment there. But let me circle up with ICBN to get their thoughts on if there's uh, some potential option that we can send out to people to use that would cover the plans for them. But basically, I think you have to be an agent to get access to that software is a short answer for
Okay.
it.
And then on the slide, Jason had a question, to go back to the Aetna Caremark slide. Does the 2024 WAC minus 1.6 going to minus 6.4 in 2025 mean Silver Script choice plans will now be likely negative on brand since most of us pay WAC minus 4 or 4.5?
So that's where we have to separate a little bit from the contract rate and what is actually in the solicitation from the potential point of sale rates. The rate that's in the contract is that minus 6.4. But if you reach out to Aetna, they will tell you many of your brand drugs will continue to be priced similar to how they are today because that contract rate is just the minimum they can pay you on individual prescriptions. But the door is still open that they can pay you better than that contract rate and pay you similar to what you are seeing today. But you do have to take it at face value and take it on good faith that they're not just going to screw us with telling us they're not going to tank it and that it'll be similar. But yeah, that's where you got to make a little bit of your individual determination there. They also require you to notify them by April to be out of network for next year. So if you have not told them you want to drop that plan, you will be in it for 2025, but could potentially get out for 2026 there.
Okay. Another question, this one's probably more to me. How are you telling your patients when you're losing money on the brand name prescriptions? So I'll just talk for a minute about that. So I'm a big fan of Retail My Meds and have used their program and system to do that in our pharmacies. And I know many of our members inside Pharmacy Badass University have used Retail My Meds as well. And it's basically you control the process of having the mail order pharmacy fill the prescription. That way they don't transfer everything. It's only just the prescription that you want to go to, which is basically brand names. And we've had no issues with patients. We tell patients that, hey, we just can't buy these drugs as cheap as we need to. And we'll handle it all for you. You don't have to do anything. We'll transfer it. We'll have it filled by whoever your mail order pharmacy is. And it's actually ran very smoothly. I will caution you though, I made this mistake in my pharmacy. So here's one of those learn from my mistakes. Don't do it yourself. Is I did not think of 340B claims because 340B claims will show up negative at the point of sale. But in fact, they're often very profitable. And we realized that we transferred a few that we didn't want to transfer and whatnot. So just it gets a little dicey to really understand which ones are profitable and which ones not when you're a 340B pharmacy. So, look at your 340B claims. Just know that those are most likely very profitable. You don't want to transfer those and whatnot. So just, anyways, learn from my mistake. We went a little overzealous and transferring for a little while. So, alrighty. So I think
real quick on that note, Lisa,
go ahead.
Humana, if you do a lot of 340B claims and you submit them with the submission clarification code that identifies them as 340B, they pay really aggressive and you're going to see around, I think it's like WAC minus 20% that you'll be paid on those if you submit it with a submission clarification code. To my knowledge, they're the only PBM that does that, but be aware if you are submitting them with the SCC code for 340B, it'll be very aggressive reimbursement.
Yeah. How do you know if they're 340B? God, I wish I knew how I could answer that. So I lean into Secure 340B. They have some really cool analytics tools. You can sometimes see in the data, sometimes it's like, oh, it's from this doctor, from this clinic. Therefore, like, I know it's covered. It's really hard based on, depending on the systems and the insurance and stuff, to know. Many times it'll get what I call swept up and identified as a 340B claim. And if you're that 340B pharmacy, you'll get the replenishment for it. So it's like, oh, I just got this extra bottle. Like, it must have been a 340B. I wish it was very super clear, but it's not always super clear at the point of sale. It's always later when you get your 340B reports, it'll tell you which one. So then you can go in there and flag them, but it's not always super apparent at the point of sale, depending on especially which software you have and what claims transmission information you see. Some softwares are very open and you can see all the claims transmission information. Those are much easier than the ones you can't see anything. And then it's really hard to identify which one's a 340B. So that's 340B for you. Alrighty. So I think that's all the questions for now. If you are watching the recording later and you have questions, feel free to submit them to me. I will compile them and send them over to Kyle kind of all at once, because that's usually easier to deal with than a bunch of onesies and twosies. So send them to me, info@DiversifyRx.com. And if you have any questions that aren't answered in the recording, feel free to do that. Anything that Kyle sends to me, I will then forward to everybody. So have no fear. And then Kyle, everybody and their brother has asked for the slides. Are you going to be able to share these slides?
Yeah, I can share them.
Okay, perfect. So we will send out the recording. We will send out the slides to everybody. And it's a heavy topic. I highly recommend re-listening to it. I know I will. There's just a lot of info here, but I learned ESI is bad, Optum good. In the TLDR of the webinar, which is a good thing to know. Caremark is still Caremark's hard because it's that iffy middle. Like, it kind of depends who you are, what you're dispensing, where you're at. And it can either be great or it could be a curse. So that one's a little harder. So thank you so much, Kyle. As always, I love to pick your brain. I learn something new every single time I speak with you. And if you don't have your tickets to the Pharmacy Profit Summit yet, you don't want to miss Kyle's session. So you absolutely, it is entirely worth the entire ticket price and trip itself. Just trust me on this. You will not want to miss Kyle's session when he talks about all the PSAO analytics and kind of the deltas you can see by changing. You could completely transform your pharmacy just from Kyle's session. So I hope that's not too much pressure, Kyle, but it's the truth. So get your ticket to the Pharmacy Profit Summit, because you do not want to miss Kyle's session on PSAOs. You can just go to pharmacyprofitsummit.com and purchase your ticket. So, all right, I will let everybody go now. Thank you for sticking with us for 90 minutes. I appreciate it. I know this is a super important topic. And thank you, Kyle, for all you do to help independent pharmacies. It's so greatly appreciated.
Thanks, Lisa. Appreciate the opportunity. Take care.
All right. Yep. Bye-bye.
Bye.